The greatest emergency that they're called to manage, and that is an unexpected cardiac arrest in the community. This is what cardiopulmonary resuscitation often looks like in hospital. So this is a photograph of an emergency department. One of the things that you'll note is that there are significant numbers of people here in this cardiac arrest team, working synchronously, being led by an appropriately experienced clinician in a well-lit environment with a patient optimally positioned on a trolley with access to modern equipment instantly available. Okay. And that can be delivered because this care is being delivered in an environment where one can predict that that care is going to need to be delivered. Again, for a good clinical outcome, that care needs to be synchronized, the team needs to be well led, and the care that's delivered needs to be evidence-based and effective. Some of the key steps that we have to get right as an ambulance service in order to successfully resuscitate a patient, and even more importantly, to obtain a good outcome, is that we've got to rapidly establish the fact that a cardiac arrest has occurred. And that can be more challenging than you may think, particularly bearing in mind that patients will often continue to breathe, albeit in an abnormal way, for a minute or two after the heart has stopped. It's clearly vital that we can rapidly access the incident location, and that's still quite challenging in 2015, as increasing numbers of our calls that comes from a mobile phone as opposed to a landline, which instantly gives us the location of the emergency. We've clearly got to get people on the move very quickly, the right people with the right skill set, as rapidly as possible. And we've done a lot of work to make sure that that happens. We've introduced some principles around keyword recognition that can enable an ambulance to be dispatched within seconds of us being alerted to a potential cardiac arrest. It's clearly also vital that anyone that's witnessed or has come across the incident is encouraged and given appropriate, clinically appropriate instructions on what to do prior to the arrival of the ambulance service. And so the main priority is to ensure that chest compressions occur in a safe environment, and that they are alerted if there is a defibrillator at the scene of collapse, because we know that for patients whose hearts need an electric shock, the quicker that electric shock is administered, the better the outcome. But the other challenges that our crews have to face on a daily basis is that patients can sustain a cardiac arrest in very difficult locations. It may be maybe in a cramped first floor bedroom, side of in a house. It may be at the roadside. There may be a number of environmental issues that actually pose significant threats and risks to anybody that's come into contact with the patient. I've said if attended patients have been electrocuted, and you can clearly appreciate that unless the scene is appropriately managed, there really is a very real potential for escalating harm and risk to the responders. All this requires experience and training. It's then vital that having got to the patient, that we deliver clinically appropriate care, using the evidence base as we best understand in terms of delivering clinically effective care. And I'll touch on this shortly. And then, having got to the patient, it's also important to establish as rapidly as possible, if known, the circumstances of the collapse. Is it clinically appropriate to continue to resuscitate the patient? Is there an advanced care plan in place? Because there may be circumstances where it's not actually appropriate to attempt resuscitation. But clearly, if it's unexpected, the default position is that we would aggressively resuscitate that patient. But again, there's some complex decision making around if we are able to resuscitate the patient, or even if we aren't able to rapidly resuscitate the patient, where do we transfer them to? Do we take them to the nearest hospital, or do we transfer them some further distance, perhaps to the nearest heart attack centre, with access to 24/7 interventional cardiological expertise? If we do decide to transfer them to hospital, do we take them straight to the cardiac cath lab, or is it more appropriate for them to be initially managed in the emergency department and then secondarily transferred? And again, these require assessments on a case-by-case basis that our staff need to have an understanding of. If we're not able to resuscitate the patient, or even if we have resuscitated the patient, there are some significant clinical challenges around delivering in-transit care that's clinically appropriate and effective. And that is often complex. That may sometimes require the expertise of a critical care paramedic, backed up on occasions by a consultant in pre-hospital emergency medicine if one is available. And again, that's been another significant area of progress, particularly when patients have complex needs post-resuscitation. It's clearly vital that if we have an opportunity to alert the emergency department that this patient is inbound, because predictably there will be some needs that will need to be addressed as soon as the patient hits the department. The handover of care needs to be effective and efficient so that the patient's management doesn't stall on arrival in the emergency department. And then clearly the principles of good governance, we've got to make sure that we've got an accurate record of what we've done so that we can review those cases and learn from it. As is often the case, whenever we look at a resuscitation attempt in hospital, there's inevitably things that could have gone better, we could have done better. Many of these incidents, particularly involving young people, children, multiple casualties, can be very, very distressing, and even more distressing in my experience in the pre-hospital environment because of the impact factor and the circumstances of the patient running into trouble, whereas in hospital we often have quite a sanitised perspective. We have a patient that's already received a level of care, they arrive packaged, we know exactly what's happened beforehand, but it's very important that our staff are supported and have an opportunity to reflect on what's happened. And it's clearly vital that family members that there's good communication with the family in terms of what their expectations are. Our crews will often assist the transfer of carers, and working with our colleagues in the police will often be a very important role for our colleagues in the police, helping to identify the casualty if they're not known, and they can very often help us bring key family members to hospital, which is often extremely important. Again, I just wanted to tell you a story really just to illustrate the challenge and importance of getting this right. So I'm going to tell you about a previously fit and well 32-year-old academic who was on sabbatical in Oxford. And early on a Saturday evening she developed some indigestion, didn't feel terribly well, felt a bit sweaty, had a little bit of heaviness in one of her arms, and decided to rest up. But fortunately she was with her husband, and shortly after, she lying down in her bedroom, she collapsed and started to breathe in a very abnormal manner. He was on his own in a flat on the third floor of an apartment block, on the third floor of a block of flats. He was able to dial 999 on his mobile phone and was able to, in fact because he was a healthcare professional, was able to institute cardiopulmonary resuscitation on his own. This occurred at 6:30 on a Saturday evening. We had a rapid response vehicle mobilised to the scene and actually arrived on scene within 4 minutes. But because of some complexity of the scene, the team weren't actually physically able to get to the patient's side for a further 10 minutes. The reason for that was that this was the address in Oxford. This was number 58 of this particular road in Oxford. And this was one of about 50 flats at this location, with multiple entrances, multiple intercom systems. And the biggest problem was that there was a set of locked electric gates here that took some time to physically open in order to get the team physically into that building. And that was despite the team shouting and obviously trying to get the help from neighbours that were in the block of flats. These were our team that responded, both 2 RRVs and a double-manned ambulance, which in fact was third manned. And this was hugely important. The patient was on the third floor of this building. The patient needed, as one would expect, advanced cardiac life support. It was established that she was in cardiac arrest due to an underlying shock or rhythm of the heart. But unfortunately, despite multiple shocks, the pulse was only briefly restored at the scene before she would then deteriorate and went back into this unstable cardiac rhythm. She received standard advanced life support care, including multiple drug delivery, including the standard drug, which we're going to hear a little bit more about shortly, adrenaline, another antiarrhythmic drug called amiodarone. And critically, it became clear to my colleagues that they weren't able to rapidly resuscitate this patient, despite this being a potentially salvable situation. So they made the key decision to rapidly extricate the patient out of the building. This involved having to negotiate 3 flights of stairs with the patient in cardiac arrest. Okay, they packaged the patient on a specialist type of scoop. They attempted to use a mechanical compression chest device that we've introduced into the ambulance service for this very type of scenario. But because of the patient's size, she was too small, in fact, for this device, so chest compressions had to be delivered manually. Approximately about 20-25 minutes after they arrived on the scene, they left the scene and they were at the John Ratcliffe. This was in the city centre, a short period of time later. On arrival in the emergency department, she needed complex care to be delivered by a team of multiple consultants in not only my specialty in emergency medicine, but we had critical support from intensive care, anaesthetics, and the input of an interventional cardiologist. This patient required complex cardiac care that was outside of the scope of ambulance service protocol. She required multiple drugs, multiple antiarrhythmic drugs, and she had over 30 electric shocks to her heart before we got a sustained cardiac output, in other words, before a pulse was restored. So this was a scenario where a patient had been in cardiac arrest, to all intents and purposes, for over 60 minutes by the time we received, before cardiac stability was restored. Because of the history, there was a suspicion about her having had a heart attack, and she underwent early coronary angiography that evening. Was then taken to an intensive care unit where she required complex cardiac care that involved cooling, very careful monitoring. But by the Monday morning, when I first met her, I wasn't directly involved in this patient's care, but when I first met her on the Monday morning, she was awake and was extubated a short period of time later. And she subsequently, after further complex cardiac care, was discharged from hospital cardiac care, and she also, critically important, received high quality care on arrival in hospital, including appropriate post-resuscitation care. So the key factors that I think had a major impact on this outcome was the fact that this cardiac arrest was witnessed, that the husband was able to effectively give chest compressions for an extended period of time before the ambulance service was able to get to the patient's side for the multiple reasons that I've alluded to. She received absolutely fantastic first-class care from an extremely resourceful SCAS clinical team that was well-led, resourceful, and critically, there was enough of them in order to be able to administer effective advanced life support while extricating this patient hospital and continuing that care en route to the emergency department. They used up-to-date clinical practice guidelines, and Professor Charles Deakin, who will be talking to you shortly, one of my colleagues, who is a member of the Resuscitation Council, has also been very closely involved working with the clinical director at SCAD to make sure that our resuscitation policies are up to date and current. We've issued further clinical updates, in fact in 2014, about this very type of scenario, about what to do if we aren't able to rapidly resuscitate a patient at the scene, recognising that some patients will require complex care in a hospital. We've also given advice to our staff on post-resuscitation care that's complex, and this again is where delivering consultants, if possible, can be of particular value, particularly if there is a need to deliver intensive care. And then clearly, it's very, very important that these patients receive clinically appropriate and expert care. And we know that one of the biggest determinants in terms of whether a patient will survive an out-of-hospital cardiac arrest is which hospital they get taken to post-resuscitation. In our board papers, we've already reviewed our current levels of performance. We're not complacent. There's a lot more that we need to do, but we know approximately 50% of patients have a pulse on arrival in hospital. But you'll note that this particular patient, that wasn't the case. And our current survival to discharge for patients having witnessed cardiac arrest is about 1 in 3, which translates to at least 1 patient a day within the South Central region. And that's hugely important. The other things that are absolutely critical for us supporting our clinical performance is around investing in further developing the training of our staff. And I thought I'd just take this opportunity to showcase a new system that's been introduced. This, in fact, is a modified control room vehicle from what was previously Royal Berkshire Ambulance Service. This used to be a control vehicle that's, in fact, been modified such that not only does this replicate the back of an ambulance, which you'll have the opportunity to have a look at, but this forward compartment here, so the inside of this vehicle looks exactly the same as a standard ambulance, with kit laid out in a standard way. We've got a highly sophisticated mannequin here that we can monitor and simulate any type of clinical emergency you can wish to think of. And in the rear compartment, there's the facility here where we can video the clinical management of the patient, provide constructive and supportive feedback for our staff. And this use of simulation very much reflects what we're doing in hospital, because it's an immensely valuable process for evaluating and testing critical decision making. Other priorities are that you'll be aware of. We've already developed an app that's freely downloadable that will tell you the nearest location of the nearest semi-automatic defibrillator. This is the south central part of England, littered with, not littered, but there are. It's a nice heart, as you can see, but those hearts there represent over almost, I think, about 2,000 defibrillators that are within the south central region that are accessible to the public. Okay. And we've also got a very active program to further roll out access to defibrillators. So in fact, this is my own hockey club in North Oxford. So this is my own personal insurance policy. But actually we have a second defibrillator in the car park, because this area is locked out of hours, so it's available for the local community to access in the event of an unexpected cardiac arrest occurring. We're further developing our cardiac networks, particularly...
John, could I just ask you, you said there's 2,000 defibrillators. If we had as many as you think we need to serve the population, do you know what that number would be?
I could get back to Professor Deakin, may be a better place to answer that question in terms of... certainly our strategy...
But we haven't yet got the number we want.
We certainly haven't. We need more. Certainly our strategy is to try and ensure that we have access to defibrillator within 8 minutes throughout the entire south central region. But clearly what we want to do is to put defibrillators at high-risk locations, which we know are transport hubs, so if you can survive the check-in process, while at Heathrow, for example, you're unlikely to have cardiac arrest in the air, but you just might. So that's why you'll see defibrillators in every place. So, but in all seriousness, we know that young people, when exercising, are at more risk than they would be otherwise, except for these are relatively rare events. I can tell you at least one 70-year-old veteran that has been defibrillated at this sports ground and made a full recovery.
John, I think the answer to Trevor's question was within 200 metres of every person within the region. So you could go away and maybe work that out.
Thank you, Sue. We have big ambitions, but we think this is...
It's a lot.
We think this is a good thing to be doing. Clearly we've got, we can talk, I'm sure Charles will be talking about that a little bit more of that shortly, but in terms of what we're further doing, we think that we can further improve outcomes by facilitating direct access to complex cardiac care when it's needed at heart attack centres. So that work is ongoing, and those arrangements are maturing. But what I really do want to focus on, and use this as a backdrop to, is that although the outcome here was good, there's an awful lot that we don't know. And we need to do much more high-quality pre-hospital care research that you'll hear from Professor Deakin very shortly.